Imagine for a moment your heart, usually so steady, suddenly starts misbehaving. Racing, fluttering, skipping beats. It's like an electrical storm inside your chest. So how do doctors actually step in and, bring it back into rhythm? Today we're doing a deep dive into the really fascinating world of anti-arrhythmic drugs. We've sifted through a bunch of articles and research to give you a shortcut to understanding these tools. The big question is, how do we manage an erratic heartbeat? What are the actual pharmacological options?
It really is quite amazing when you think about it. Managing these cardiac arrhythmias, these unpredictable electrical issues, is absolutely vital. We'll explore the four main classes plus a few really important standalone drugs. Our aim isn't just to list them, but to give you a real feel for how they work when they're used, and also importantly, their potential side effects. A solid, digestible overview.
Okay, let's jump in. Class 1 anti-arrhythmics. You called them gatekeepers earlier. I liked that. What's their main job? How they work, fundamentally?
Gatekeepers is a good way to put it, yeah. Class 1 drugs primarily target heart cells that have become, let's say, hyperexcited. Firing too fast, they quiet these cells down by blocking their sodium channels, the N channels. Think of these channels as little doors for the electrical signal. By partly blocking those doors, they slow down how quickly the cell charges up or depolarizes. This is really crucial for things like radio reentrant, tachycardias.
Those electrical short circuits.
Exactly. Where the signal gets stuck in a loop, causing a sustained fast rhythm. Class 1 helps break that loop.
Okay, and you mentioned something really clever before. Use-dependent blockade. What exactly does that mean? Why is it so smart?
Right, use dependency. It's quite elegant, actually. It means the drug doesn't just block channels all the time. It binds more effectively when the channels are being used frequently. So during a fast, abnormal rhythm, like a tachycardia, precisely, when the channels are opening and closing rapidly, the drug has a stronger effect. But at a normal heart rate, it mostly leaves the channels alone. It selectively slows depolarization and increases the refractory period, that rest time, mainly in the fast-beating cells.
So it targets the problem without messing too much with the normal rhythm. That is clever. But they're not all the same, are they? There are subclasses, correct?
Three main subclasses, each with a slightly different twist on blocking those sodium channels. First, you have Class 1A. These have kind of intermediate binding speed. What's really key here is they also prolong repolarization, the recovery phase, and the whole action potential duration. Clinically, this makes them useful for those re-entrant tachycardias, both atrial and ventricular, because they extend that crucial rest period.
Okay, intermediate action, longer recovery.
What about ABE class 1B class, like lidocaine or lignocaine and toconide? These are the opposite. Very fast, they jump on and off the channels quickly. This actually shortens the plateau phase and reduces the action potential duration overall.
Fast on, fast off. So where would you use those?
Their speed makes them really good for acute situations, especially ventricular arrhythmias, maybe right after a heart attack, like a rapid response team.
Got it. And the third one? 1C.
Class 1C, encainide, flecainide, and propafenone. These are, well, the heavy hitters, the most potent sodium channel blockers. They bind slowly and come off slowly, so they really slow down that electrical recharge significantly. Interestingly, they do this without really changing the overall action potential duration that much.
Wow, potent and slow acting?
Yeah, very effective for things like atrial fibrillation or flutter. They provide a strong, sustained calming effect.
So looking at class 1, it's really about picking the right tool, isn't it? Tailoring the blockade to the specific electrical problem. It's not just one drug, it's a precise choice. Okay, so class 1 tunes the internal wiring, but what if the issue is more like the heart's accelerator pedal being stuck down, like that constant fight or flight signal making it race? That seems like a job for a different approach. Which I guess brings us to class 2 anti-arrhythmics. The beta blockers. How do they calm things down?
That's a perfect analogy. Class 2 drugs are beta adrenergic antagonists. Their main role is to block the effects of the sympathetic nervous system, that fight or flight response. By doing that, they reduce heart rate, they reduce the force of contraction, and basically lower the heart's overall workload, like turning down a dimmer switch.
Okay, makes sense. Can you give us some common examples?
Sure, widely used ones include propranolol, esmolol, atenolol, and ependolol too. It's worth noting, though, that sotalol, while it is a beta blocker,
Right, you mentioned that before.
yeah, it's actually classified as class 3 because it also significantly blocks potassium channels. We'll get to those next.
Okay, so focusing on the beta blocking part, how does physically blocking those beta 1 receptors achieve the calming effect? What's happening at the cell level?
It's all about interrupting a signaling cascade. Normally, stress hormones like norepinephrine bind to beta 1 receptors on heart cells. This triggers a process that increases something called CAMPI, which then makes the cells more permeable to sodium and calcium.
Leading to faster heart rate and stronger beats.
Exactly. Beta blockers just get in the way. They block those receptors, stop that cascade, prevent the increase in KMP, and so the heart rate slows down and contractions become less forceful.
So they effectively shield the heart from stress signals. What conditions are they typically prescribed for?
They're very versatile. You see them a lot in atrial fibrillation, mainly to control how fast the ventricles are beating, also for supraventricular tachycardia or SVT. And beyond arrhythmias, they are mainstays for hypertension and angina, especially if high blood pressure is also an issue. They just ease the load on the heart.
That leads to a really important point. Safety. What are the critical things to watch out for? Contraindications, side effects.
Absolutely crucial. A major one is respiratory conditions like asthma. Some beta blockers can cause bronchoconstriction, making breathing harder. That's a big no-no. And perhaps the most critical warning, never use them concurrently with calcium channel blockers
Why is that combination so dangerous?
because both classes dampen the heart's activity, particularly calcium influx. Together, they can cause a profound, potentially fatal slowing of the heart, severe bradycardia, other side effects, while sinus bradycardia, just a generally slow heart rate, is common. And importantly, you can get rebound tachycardia if you stop them suddenly.
So the heart overcompensates.
Right. That's why they always need to be tapered off gradually, never stopped abruptly.
Okay, we've covered sodium channel blockers and beta blockers. Let's shift strategy again. What about trying to extend the heart cell's recovery time? That brings us to class 3, the potassium channel blockers. How do these work?
These drugs take a different angle. Yeah, they primarily block voltage gated potassium channels. These channels are key for the repolarization phase, the heart cell resetting itself after a beat. By blocking them, class 3 drugs prolong the plateau phase of the action potential. This stretches out the cell's relative refractory period and increases the total action potential duration.
Making the cell less likely to fire again too soon.
Exactly, it decreases that hyperexcitability, stabilizing the rhythm.
What are the main drugs in this class, and when are they typically used?
The big ones are amiodarone, and as we mentioned, sotalol. They're often first-line choices for stubborn reentrant tachycardias like ventricular tachycardia, and also very effective for managing atrial fibrillation and flutter, especially when other drugs haven't worked.
Now, here's the tricky part I find fascinating. These drugs designed to stop arrhythmias can sometimes cause new ones. How does that happen?
It's a real paradox, isn't it? It highlights the fine line we tread because they significantly prolong that action potential duration, that long reset period. They can sometimes TR something called early after depolarizations or EADS.
EADS? What are those?
Think of it like an electrical echo. During that extended recovery, the cell can spontaneously fire again prematurely. This unwanted spark can actually initiate a new dangerous arrhythmia, like Torsades, the point.
Wow. So, a potential downside of prolonging the recovery too much.
Precisely. And it's also worth remembering what we touched on earlier, the promiscuity of some agents.
Right, like sotalol being class 2 and 3.
Exactly. Sotalol blocks beta receptors too. And even procainamide, which is mainly class Ia, has some class 3 potassium channel blocking effects. This overlap adds complexity, but also therapeutic options.
Interesting how they can wear multiple hats. Okay, let's move to class 4, the calcium channel blockers. How do these work and where in the heart do they primarily act?
Class 4 agents focus on blocking voltage-gated calcium channels. Their main targets are the heart's electrical control centers, the sinoatrial node or SA node,
The natural pacemaker.
right? And the atrioventricular node, the AV node.
The junction box or traffic controller.
Good analogy. By blocking calcium entry in these specific nodes, these drugs slow down depolarization. This means they reduce the heart rate set by the SA node, and importantly, they delay the signal passing through the AV node. They also tend to cause vasodilation, relaxing blood vessels.
Okay, what are the key examples here? And do they all do the same thing?
The main ones are verapamil and nifedipine, but they're quite different in their focus. Verapamil is more heart selective. It directly impacts heart rate and AV node conduction. Nifedipine, on the other hand, is much more selective for calcium channels in blood vessels.
So nifedipine is more for blood pressure and angina.
Primarily, yes, used more for angina and heart failure because of its strong vasodilatory effect, though it still has some cardiac influence. Verapamil is more directly anti-arrhythmic for the heart itself.
Makes sense. So what are the main conditions class 4 drugs are used for?
Given their action on the AV node, they're very useful for supraventricular tachycardia, SVT, slowing down those fast rhythms coming from above the ventricles. Also used for variant angina, that's spasm-related chest pain.
And this brings us back to a critical warning you mentioned earlier.
Yes, absolutely critical. The major danger is using them concurrently with beta blockers.
Because they both slow things down too much.
Exactly. Both inhibit calcium influx either directly or indirectly. The combined effect can lead to profound, potentially fatal bradycardia. It's a combination to be extremely cautious about. Other side effects include things like heart block, general bradycardia, hypotension, low blood pressure, and dizziness.
Right. Good to be aware of. Now, beyond these 4 main classes, there are some really interesting standalone agents. Unique mechanisms, crucial roles. Let's talk about digoxin first. It feels kind of old school, but still important.
Oh, absolutely. Digoxin is quite special. It's a cornerstone therapy for heart failure, improving the heart's pumping strength. But it's also very effective for managing SVT, especially if the person also has atrial fibrillation. It tackles both contractility and rhythm control.
How does it do both? Increasing pump strength and slowing the rhythm seems almost contradictory.
It's clever chemistry. In the main heart muscle cells, it inhibits an enzyme, the NAKATPase pump. This indirectly leads to more calcium inside the cell, which boosts contractility, makes the pump stronger. Then specifically in the AV node, it activates certain potassium channels. This makes the node cells harder to excite, effectively slowing down the electrical signal passing through. So slower heart rate.
2 distinct actions from one drug. Very neat.
But like the class 3 drugs, it also carries that risk of causing early after depolarizations, those EADS.
Okay, what are the key precautions with digoxin?
First, you generally don't give it if heart rate is already below 60 beats per minute due to the risk of further bradycardia or heart block. It also has a narrow therapeutic window, meaning that dose has to be managed very carefully to avoid toxicity, and monitoring potassium levels is crucial, especially if someone's on diuretics that waste potassium. Low potassium makes digoxin toxicity much more likely.
Got it. Careful dosing and monitoring. Now, adenosine, you said this one's like something from an ER show.
It really is. Adenosine is key in emergencies. It's used both diagnostically to figure out if a fast rhythm is VTach or SVT, and therapeutically, its action is incredibly fast, and its half-life is literally seconds. Seconds makes it perfect for acutely stopping an SVT episode right then and there, like hitting an emergency reset button. But it's not for long-term control. For that, you'd use something like Digoxin or a beta blocker.
How does it work so fast? What's the mechanism?
It activates specific adenosine receptors in the SA and AV nodes. This does two things: opens potassium channels, letting K rush out, and inhibits calcium channels. Both actions hyperpolarize the node cells, make them much less likely to fire, drastically slowing conduction, especially through the AV node.
And that helps differentiate VTAT from SVT. How?
If you give adenosine and the heart rate plummets, it strongly suggests the problem originates above the ventricles and relies on the AV node. So SVT. If the fast rate continues pretty much unchanged, the problem is likely originating in the ventricles themselves, bypassing the AV node, suggesting VTach.
Fascinating. And you mentioned a pretty dramatic side effect.
Yes, it's well known. Patients often report an intense, overwhelming feeling of impending doom, like they feel they're about to die.
That sounds terrifying.
It does, but thankfully it's extremely brief because the drug is cleared so quickly. Still, it's a powerful effect, and importantly, an overdose could potentially trigger VTACH.
Right, always that balance. Okay, last one. Atropine. What's its main job?
Atropine's main gigs are managing bradycardia when the heart rate is too slow, and also acting as an antidote for certain types of poisoning, like nerve agents or some pesticides. Its mechanism is pretty straightforward. It's a muscarinic antagonist. It blocks the M2 receptors that the vagus nerve uses to slow the heart down.
So it blocks the heart's natural brakes?
Essentially, yes. By inhibiting that vagal tone, it allows the heart rate to increase. But again, the caution. While it speeds up a slow heart, too much atropine can push the heart too fast and potentially cause ventricular tachycardia.
Wow. We've covered a lot of ground, from the Class I sodium channel gatekeepers to the Class II sympathetic brakes, the Class III potassium prolongers, Class IV calcium calmers, and these unique standalone agents like digoxin, adenosine, and atropine.
We really have, and it hopefully highlights the incredible precision involved in treating heart rhythm problems. Understanding these classes, their mechanisms, their specific uses, and their risks is just so fundamental to good patient care. Each offers different benefits, different risks. It really underscores why treatment has to be tailored so carefully to the individual patient and their specific arrhythmia. It's definitely not one size fits all.
So the big takeaway for you listening is the sheer sophistication required. It's not just about stopping a bad rhythm, but understanding the why behind it and choosing a very specific tool for that precise electrical glitch. Which leads me to a final thought for you to ponder. Given this delicate balancing act where drugs targeting one aspect of the heart's electrical system can have knock-on effects, what kind of surprising, maybe unintended consequences might pop up when a drug designed for one issue inadvertently tweaks another part of that complex system? The body's interactions are endlessly fascinating. Thank you so much for joining us on this deep dive into anti-arrhythmic drugs. We hope you feel more informed and maybe even more amazed by the science working to keep our hearts beating right.
If you liked the video, click like and subscribe to the channel. Click the bell to get notifications about new uploads.